Welcome everyone to our webinar today on lessons learned in the COVID-19 pandemic. My name is Jason Weiner. I'm the Senior Rabbi and Director of the Spiritual Care Department at Cedars-Sinai in Los Angeles. And today we're going to hear from chaplains and leaders from a variety of health systems and academic institutions to discuss what they've learned about spiritual care in the COVID pandemic, how their practice has changed, and what chaplains should be considering as they adapt their work. I'll take just a moment to introduce our panel. So moderating the discussion today will be my colleague, Reverend Pam Laser. She's an incredible ACPE certified educator and manager for the Cedars-Sinai Clinical Pastoral Education Program. We're joined today also by another person I'm a big fan of, Tahara Akmal. She is the Clinical Pastoral Education Manager at MedStar Washington Hospital Center in Washington, D.C. Tahara is an ACPE certified educator, actually the first Muslim woman in ACPE's history, and serves as an Adjunct Professor at Moravian Theological Seminary in Bethlehem, Pennsylvania, where she teaches in the Chaplaincy program. Tahara is also a visiting faculty member at Bayan, and where she teaches in the Islamic Chaplaincy program, and she's currently a PhD student at Alverin University in Leadership and Chaplaincy Education. We're also joined by Dr. Deb Marin, who joins us from Mount Sinai Hospital in New York. Dr. Marin has held several leadership positions, including Chief of Geriatric Psychiatry, Medical Director of the Department of Psychiatry, Dean for Clinical Research, and Chief Medical Officer. At Mount Sinai, Dr. Marin's research focus has been on the area of memory disorders, including NIH-funded grants that have investigated the clinical and biological correlates of normal aging and dementia. Her clinical interests include the treatment of memory disorders and depression. She has authored over 80 publications. And Dr. Marin's teaching interests are not only in the area of psychiatry, but also in the area of improving physician-patient relationships. And finally, we are joined by the one and only Wendy Kadge, who is the Barbara Mandel Professor of Humanistic Social Sciences and Senior Associate Dean for Strategic Initiatives at Brandeis University, where she teaches sociology and in women's, gender, and sexuality studies. Professor Kadge founded the Chaplaincy Innovation Lab in 2018, and is an expert in contemporary American religion, especially related to religion in public institutions, religious diversity, religion and immigration, and religious and moral aspects of healthcare. On behalf of Cedars-Sinai's Spiritual Care Department, let me thank our incredible panelists for joining us today, and for all of you for being with us in this webinar. I'll turn it over now to Michael Skaggs from the Chaplaincy Innovation Lab, who will say a few words on some of the technical matters.
Thank you, Jason. I just want to remind everyone that this event is being recorded, so you don't have to worry about taking notes as everyone's talking. You can always go back and view it later. We'll post it up on the website of the Chaplaincy Innovation Lab here in the next couple of days. We will have a Q&A portion at the end, like we do with all of our webinars. You can use the question function on your control panel on the right-hand side. You can put your questions in there. You can also put them in the chat, but it's a little bit easier for us to see if you put it in questions. If you have any technical difficulties during the webinar, feel free to send me a message there in the chat box, and I'll do what I can to help you out as well. So with that, I will get out of the way and hand it to Tahara, who's going to get us started. Sorry, Tahara, you're still muted.
Can you hear me now? Okay. Thank you, Michael, and thank you to my panelists for the invitation to join you today. I just want to start off with thinking about how chaplains are trained, especially in our CPE programs. Chaplains are typically taught to assess patients and their families holistically, to look at not just the spiritual aspects of what patients and their families are experiencing, but to look at their whole story and what's going on with them. So I'd like to start with a quote from the Dictionary of Pastoral Care and Counseling that says, "The transition from health to illness is experienced by most persons as undesirable, stressful, and often traumatic. The course of any debilitation illness is likely to involve pain, suffering, worry, fear, anxiety, bitterness, unfamiliar surroundings, bed rest, and consequent physical weakening. Family and financial strains, lack of privacy, relative social isolation, and a sense of human vulnerability and frailty. Further, the patient and his or her family may be faced with experiences involving guilt and forgiveness, diminished self-image, limited future prospects, and questions concerning the meaning of life, death, and theodicy. None of these experiences is unique to the sick. All can be known in the best of health, but in illness they are intensified. Again, that's from the Dictionary of Pastoral Care and Counseling by R.J. Hunter. And I think about that because I usually use that when I'm teaching CPE students when they're talking about spiritual assessment of patients. But during the COVID-19 pandemic, I think this is more important than ever. Our assessment starts with, the person coming in to see us at the hospital, and normally their family is with them. But during COVID-19, the families are not a part of the care team at all times. So how do we assess people holistically and provide care and support as we're experiencing a time of intense need? The changes that we've had to adapt to in our hospitals, spiritual care departments, and even in our education programs have been abrupt and were unexpected. Our institutions have had a great need for care and support for all within the institution and the system, which, as the quote points out, that life struggles are often amplified when experiencing illness and hospitalization. COVID-19 has impacted everyone's life and continues to do so with no clear indication of what is next and what the future holds. Our country is in a time of grief over many things. The fear and anxiety of trying to stay safe and healthy away from others has moved us into isolation from others. Our institutions have needed policy changes to manage or restrict who can come into our hospitals as a way to manage the disease. The pandemic has moved our spiritual care departments to look at how we care for patients and their families and staff at a time when visitors are restricted and the institution is looking at new policies on how to keep us safe. One of the lessons I think that I've taken away from this experience is to also look at the parallels that are happening in our community. So when we think about patient care, we also have to look at what's happening in our world around race and cultural relations. There's a quote in the book called How to Survive Change You Didn't Ask For by M.J. Ryan that is attributed to Dorothy Allison that says, when change comes, it cracks everything open. And I interpret that to mean shifts and changes can initiate the opening of floodgates that explore things, our vulnerabilities, our fears and anxieties, such as what's happening in our country right now. The uncertainty and grief that we and many across the country are experiencing with COVID also parallels the uncertainty and the fear happening in our communities around racial dynamics, and protests are happening to address those issues. The COVID-19 pandemic does not discriminate. Alongside of the pandemic, we have had to acknowledge that there are people who feel marginalized and less than, and there are health disparities that indicate that. So as I think about what's changed and what are some of the lessons, that the parallel of what's happening in our community alongside of our patients who are coming in with health concerns around COVID or whatever they're here for, there's a parallel process. Another lesson that I've learned from this is that the important role of chaplains, how we demonstrate the care and the leadership to our institutions where we supply our support. The chaplain's leadership within our institutions is crucial now more than ever. Our leadership teams look to the chaplain and spiritual care departments for guidance, education, and support for the staff in policy making, decision making, ethics, and of course, spiritual faith and cultural, even emotional care. As spiritual care providers, educators, and leaders, we demonstrate to one another and to our institutions how spiritual care is integrated into the system's mission, vision, and core values. Some of the changes and lessons that we have to learn at my health system around patient care is we've had to make adjustments. We've had programs called No One Dies Alone, where we've had to shift that because we don't have our volunteers coming in the way they used to. Now the staff, more than ever, is showing up for our patients during times of end of life. Our chaplain department, we show up for individuals and provide care and support for the floors, for the departments when we're needed. And CPE has historically taught students to learn to lean into their leadership, to lean into their pastoral authority, and to invite the health system to hear their ideas, to hear their recommendations for how we can improve and integrate spiritual care more into our health systems. And we've done that during the COVID-19 pandemic. One of the things that we've done to be more visible to the staff and to show the staff that we are consistently here for them is on the hospital monitors that are all around the hospital. We started in April implementing a monthly chaplain reflection that appears on the monitor, and it shows a chaplain's face, so they know our face, because right now we're covered in a mask, but they see our face, they see our name, and they also hear a word of encouragement. We've had words of encouragement about hope, new beginnings, transition, and hope. And we also include a quote to remind the staff here that we are here for them. And again, as a reminder that we're here and that we try to offer a word of encouragement to them. Another thing that we've done to integrate ourselves more fully into the health system is we started having conversations with leadership in our palliative care, in our patient experience departments, to integrate our spiritual care department more into the patient and family support. Those are two projects that got implemented during the COVID-19 pandemic. Also, we have also started getting our students more involved in ideas about research. Our continuing residency program that will be just starting in this month, we're looking at ways that we can provide research on the impact of chaplaincy during the COVID-19 pandemic. And then finally, before I pass on to Deborah, I would like to say a couple more words about when I think about what could be next for us. We don't have a date or a really time frame of when this COVID-19 pandemic will start to change and when things will shift for us. So what does our future look like? I think the grief, part of the grief that we have as a community is not knowing, not being able to plan, living in uncertainty, living in anxiety. So part of the interdisciplinary work is having conversations with the team about those issues, about not knowing what's next, not understanding when this may come to the end, and really providing support for our medical team, who some are talking about their experiences with us and, you know, being mindful of any burnout, compassion fatigue, moral injury, and providing support for those individuals. I think I will go ahead and pass it on to Deborah at this time, and then I'll be ready to answer some questions during the Q&A. Thank you very much.
Thanks, Tahara. It's hard to follow that presentation. It was brilliant. So just a little backdrop of, I'm not a chaplain, I'm a psychiatrist. I actually have two roles that are related to lessons learned regarding the pandemic. I am the director of the Center for Spirituality and Health in the Icahn School of Medicine, Mount Sinai, and we have chaplains deployed in all our hospitals. And while we have local leaders that they work with, everybody reports up to me. And our center, Wendy knows, I'm working closely with the chaplaincy lab. You know, we've been, you know, we're known for being very evidence-based in what we do, which is makes us stand out somewhat. We do a fair amount of research. We do a lot of community engagement as well, and I'm sure the chaplains departments do as well. So my experience on talking to you is, first of all, what happened starting at the first week of March is, as you know, we are no longer the epicenter. We were the epicenter. Our hospitals basically became COVID hospitals. I am based at Mount Sinai Hospital, 1,100 beds, all of which became COVID beds. And the death rate would go from 2 or 3 folks a day, and pre-COVID up to 19 people a day just at that one hospital. Some of our hospitals had death rate at the end of March that approached the annual death rate, so it was quite challenging on many levels, and we had to turn on a dime. Fortunately, in our health system, the chaplains are very much viewed as really good leaders by leadership. They are in the morning huddles with presidents every day before pre-COVID, so they have they've been exposed to all different disciplines. Prior to COVID, we've been keeping tabs on how much chaplains take care of actually our staff, and on average, chaplains spend about 20% of the time taking care of staff, either individually in groups. And I bring that up because what happened in March was that all the different departments, human resources, social work, psychiatry, and the chaplaincy got very involved in gearing up for what had to happen for patients. Of course, the biggest change was chaplains did not go into patients' rooms. They walked the floors. They took care of patients through the glass doors. And it was basically telechaplaincy, just started the way it was. And what the chaplains did is that we realized we had to be a 7-day-a-week operation. A fair number of our chaplains at one site got sick early on before social distancing was known. So we were down actually 25% of our staff at Mount Sinai Hospital. And that took a lot of work on the part of our different directors, and David Fleener, who runs our CPE program, and Joe Hirschman, who also directs it, to redeploy chaplains in a different way. We did redeploy one chaplain to a hospital that did not have a chaplain available because their head chaplain had medical conditions that he could not come in. And that was the most hard-hit hospital. The chaplains were intimately involved in a tremendous amount of palliative care, end-of-life experiences, the National Palliative Care Department, Amy Myerson, for chaplains who know her. And the biggest challenge, quite frankly, was meeting the need of both the patients and the staff. So we were lucky to have great help from our chaplain colleagues on the country who volunteered and did telechaplaincy for us. And documentation, they could not document in Epic, but our chaplains documented that they saw people, so we could keep tabs on it. As the pandemic continued, the staff care became a very big issue, and the hospital health system started keeping data on who was being used for one-to-ones and groups. And the chaplains, we have altogether basically 20 chaplain systems. The chaplains were the most used resource of any department in the hospital for staff care. It was astounding. And I think a big part of that goes to the fact that the chaplains are trusted individuals. They listen. So while our chaplains, and I do want you to know that I don't think it's yet been published, Mount Sinai is having a paper that's in press now about the psychological effects of COVID on healthcare workers. And of 6,000 folks who were asked to fill out a survey, and chaplains were included in that survey, we had information about 3,000 folks, and 40% of our staff met criteria for either post-traumatic stress disorder and or major depression and or general anxiety disorder. So that, I want to turn the dial therefore on what has gone on at Mount Sinai as a result of these findings, and because we're very well known for work with the first responders for the World Trade Center, and we're a hub for a lot of work in anxiety disorders and PTSD. So, and the chaplains are integral to the next step I'm talking about. So I also now direct the Center for Stress Resilience and Personal Growth. It is an inward-looking center that is there to take care of all 42,000 plus employees in the health system. And we've developed resilience workshops that focus on the 10 themes of resilience. We offer free screening, and we're offering actually a limited amount of free care to all employees. We're the chaplains for that. The biggest part about getting this going, this new center, which is just 5 weeks old to today, is community engagement. And that requires a lot of trust on the part of the staff, and our chaplains have it. So we have now trained, it's a peer-led resilience workshop model, and all chaplains have been trained, and only they and trained social workers in our center are going to be running workshops on their own for employees. They will be co-leading with leaders of different disciplines. We now have over 60 peer leaders that have been trained. We're working with physician assistants and the unions and nurses as well to get the word out. There also are the only group of people who will be allowed to do what's called coaching, one-to-one coaching. And I bring this up because we have a wonderful social work department at Mount Sinai. There's no question about it. But of all the people that are really trusted for staff care, it is the chaplains. And in fact, in this time of budgets being very tough, as you can imagine, I'm sure Cedars-Sinai and elsewhere too had a lot of fiscal issues that have gone on. We lost a tremendous amount of money, you can imagine, many, many millions. We were allowed to hire a financial chaplain, specifically with regards to taking care of patients, but also taking care of staff for these workshops. So I really have to say chaplains, the one difference is now chaplains are going to have something that they don't necessarily do all the time, where they're going to have to not only listen but act, because coaching involves helping people on their resilience plans. So they're very involved in that. So I think the lessons learned, and I'm speaking for chaplains, is that chaplains were remarkably willing to be redeployed. There was no issue. I did not have to ask anybody to do something that they didn't want to do. To send a chaplain resident to a small hospital in Brooklyn to be the chaplain, never been there before. And if they had the money, they would have hired him too, by the way. Now, unfortunately, we couldn't do that for him. Really struck me because a lot of the workers were very hard hit. The percentages I gave you, the flexibility and the collegiality of other chaplains from other folks outside of Mount Sinai Health System to help us was very, very striking to me, I must tell you. And the fact that the chaplains are critical pieces of this new center that we have, I think is a lessons learned for other folks too. I think chaplain centers don't get the word out about themselves well enough with what they can do. So I would say one lesson learned is keep data on what all these chaplains are doing for staff, because it goes a long way. Our budget is not going to be cut, you know, and as you all know, everybody's looking to cut right now. So I think really managing yourselves up and getting the word out about what you can do for staff and having data. And if you need a RECAP database to teach you how to document, I'm happy to share what we've done. It's a very simple thing. I'm happy to help in any way I can with that. Wendy knows how I feel about this. You know, if you don't document it, it's hard to prove that you did it. So I think that's what I can contribute to this very special book. Wendy, it's all yours.
Thanks, Deb, and thanks, Tahara. It's such a treat to be with both of you, and a huge thanks to Cedars-Sinai for co-sponsoring this webinar with us. I thought I might start with a few personal lessons learned from COVID-19. As I said to the panelists as we joined before this, my partner just took our children to Target so that you would not hear them screaming in the background. So they're 6 and 9. One of them turned 6 on Saturday. So personal lessons learned, it's really hard to work without childcare. And this, I think, keeps dropping off the national radar in ways that boggle my mind. For me, going outside and walking around the block in the morning for 5 minutes makes my whole day go better. And when I'm really stressed out, I go out in my backyard and I look at the sky, and I'm thankful to be able to see the sky. So to sort of remember and keep the big perspective, just to try to keep ourselves going through what is clearly a marathon and not a sprint, I think is really important. Lessons learned for and about chaplains. I've got about 5, so let's see what we can do. Someone told me in an interview once that you don't need a chaplain until you really need a chaplain. And I think as we find ourselves in the midst of this double pandemic of COVID-19 and systematic awareness of systematic racial inequality that has been with us for a long time, there are a lot of people that really need chaplains and are seeking them out in ways they never did before. So certainly we see in healthcare, as Tahara and Deb have mentioned, much more staff care, staff struggling with uncertainty and anxiety, chaplains filling the gaps when family members are not able to be with loved ones when they are ill. So we see a lot of demand, certainly in healthcare. I think we see a lot of demand in protest movements. And there was a great article on Friday or over the weekend about protest chaplains. Maybe, Michael, you can drop it in the chat. Looking at our friends at Faith Matters and the work that Mickey Scott Bay Jones is doing there, supporting protest chaplains in the midst of everything that's happening on the front lines there. So I think none of us need a chaplain maybe until we really need a chaplain. And part of what's interesting to me in the midst of this double pandemic is that it feels like the media has suddenly discovered chaplains. And when we have reporters call, I tell them all the same thing. The chaplains are not suddenly running towards the dying. They've been doing that all along. And I tried to say it in a nice way, but the message is you just noticed, right? The chaplains have done this quietly and around the edges, and so much of what they do is in the interstices, in the quiet moments, in the suffering that's not on the front pages of the newspapers. And I don't want us to overlook that history, because I think when you really need a chaplain, suddenly they're being called because hospitals don't have anything else to offer. There's no one else they can maybe deploy if they're deemed essential workers to be at bedsides. But the history is really long. So that's one of my lessons. My second lesson is what we're seeing here, which is that there's a demand. And we know that there's demand. But what we see right now, I think, is a kind of sort of exponential indicator of demand because so many people are struggling. There's so much suffering. And increasingly in the lab, we're thinking about demand-based models for chaplaincy, right? What happens if you can, even just for a few minutes as a thought experiment, put to the side your assumptions and what you know about how chaplaincy has always worked, and just ask yourself where it's most needed, and then ask yourself if it's there. Are chaplains with isolated elders who haven't been out of their homes in weeks? Are they able to be with people like my grandfather, who's in a retirement nursing facility and has not been allowed out of his room for many weeks? Are they in the streets with people who are suffering, or with the unhoused who are trying to find ways to quarantine in the midst of being unhoused in the midst of a double pandemic? And I think the answer is yes and no. There are chaplains in some of these places and not others. And I think the challenge for all of us is to think about how to shift the models so that we're responding to demand. We're getting chaplains where there are opportunities. And part of that, I think, and I'm going to come back to this, is really recognizing and beginning to talk and think about systematic inequalities in who receives spiritual care and in who provides spiritual care. We don't have good data on this, but I've thought about it for many years, and eventually maybe we'll figure out how to get it. But you know, what kind of spiritual care is being provided in communities of color? How many chaplains are people of color? And what are the barriers for people of color and other people in marginalized groups to getting the training or the education they need to do this work? I've heard too many stories from chaplains of color who work in the VA who will tell you that if there are only 1 or 2 chaplains of color in a given VA, and depending on where in the country you are, there are often many more patients of color, and they're trying to be the chaplain for all patients of color. That's impossible, it's unsustainable, and it's wrong. And I think we need to think really hard, especially in this moment, about how to build and fix the pipelines that make sure that different forms of spiritual care that are appropriate to different people, this is not a one-size-fits-all model, are available. So my first message is you don't need a chaplain until you really need a chaplain. My second message is there is demand. Are we meeting it? And are we recognizing the systematic inequalities in the places where we're not able to meet it? My third lesson is that there's a lot to learn from each other. And I've been heightened and made hopeful and inspired by all of the ways that healthcare chaplains have called their military chaplaincy friends in the military, or they've called us in the lab and said, I don't know what to do. There must be military chaplains who've had to deal with mass casualty. Can you find me one? And the answer is yes, we can find you one. And those connections and the possibility and the learning that has come through those connections gives me a lot of hope for meeting the demand. We also, and maybe Michael can put in the chat box, have some money from the Henry Luce Foundation to re-grant to chaplains who are working with staff on the front lines in partnership with administrators in their organizations. So these are micro grants up to $50,000 that you can apply for. Michael will put the link. I'm not going to get the deadlines right off the top of my head, because we want, and the Luce Foundation wants us to get money to those of you on the front lines who are trying to meet the demand and who are learning from one another, other chaplains, other staff in your healthcare organizations. The last thing I want to talk about is that sadly, in many places, not thankfully at Mount Sinai, as Deb was talking, but for chaplains in many places, employment is precarious. And we're hearing more and more about furloughs. We've heard about a lot of people being furloughed in healthcare as well as in higher education. Shelley Rambo and I talked with a group of chaplaincy residents here in Boston who are struggling so much with issues around employment, unemployment, people finishing residencies and looking for positions. We had a wonderful intern from Swarthmore College this summer named Julianne, who put together a new link on our website about all the places you could look for chaplaincy jobs. We don't have the answers to these questions, but I think it's really important, especially for our newer and our younger chaplains, to acknowledge really publicly the challenges of employment and the loan burdens. So we're starting with another intern, it's not finished yet, trying to put together information about how much it costs to become a chaplain and how much you are then paid as a chaplain. And I don't want to do this because I don't want to scare people away from the work of chaplaincy and spiritual care, which for so many is a calling. And I think we need to go in with our eyes wide open, being aware of the really serious sort of economic challenges to doing this work, and particularly to doing this work in this time. So 4 lessons that I've learned, in addition to your kids should be at Target when you're on a webinar, are about not needing a chaplain until you really need one, recognizing demand, learning from one another and seeing systematic inequalities in that process, and continuing to be aware of and talk about the precariousness of a lot of the work of chaplains. I believe increasingly that religious leadership is going to look more like chaplaincy than that it's going to look like local congregations, but that requires a totally different financial model. And from what we can see, many hospitals have full-time chaplains, some colleges, federal prisons, the Veterans Administration, the military, but so many more chaplains are working in the gig economy, piecing together different positions. And that's a hard thing to do for anyone, particularly when you're carrying the loan burdens that some are. So I'm going to stop there. Thank you again so much for being with us. Put your questions, please, in the chat box, and I look forward to getting to talk with all of you.
Well, thank you so very much, Tahara, Deb, and Wendy. This has certainly been an incredibly rich time of learning under a tremendous amount of pressure. A good question that has been asked is this one here. I will be beginning a chaplain residency in late August. I've been away from hospital staff since March because my internship was suspended. My biggest concern is that I will have lost ground with the hospital staff since I was away when the virus broke out. Any thoughts?
Hi, Pam.
Hey,
Can you read Can you read just the very last part of that?
Sure. My biggest concern is that I will have lost ground with the hospital staff since I was away when the virus broke out. Any thoughts?
I'm not sure if I'm going to be answering this properly because it sounds like they used to work at the hospital and they're coming back as maybe a resident, a CPE resident. I would say just to kind of make this feel as natural as possible. Everyone is kind of struggling with connection right now, especially in the hospital setting where we have to be distant from one another because of the COVID-19. Coming into the residency program, I would imagine that the hospital setting is going to do, in the CPE program where they're going to be, it's going to do everything that they can to help them to feel acclimated and integrated into the system. And if it's comforting at all to know that, I would say most of us are feeling that sense of disconnect. Even me being here and present, I still have this sense of disconnect because as I'm walking around, I always have to have this on. I don't see smiling faces. I can't hug anyone. So it's something I think that we're all living with. I would maybe encourage them to understand that a lot of people are in their shoes, and that I would imagine that their program is going to help them to feel integrated, to be seen the best way they can, and to be acknowledged and connected.
I would share that a lot of the workers at Mount Sinai, the social workers, for example, work remotely a tremendous amount of time. I would think if this person is being asked to be a resident, they must be liked at their institution. So if anything, I think they're going to be welcome. Oh my God, it's good to see you again, you know. So I actually think, and since chaplains are so good at listening, I suspect they're going to hear a lot from the folks with whom they're going to work.
Yeah, I think a reminder of the principles of what we do as chaplains, right, which is to show up and be present. And I'm even thinking, based on some of what was said, that with Wendy, you talking about this being a marathon and not a sprint, you know, is that it may actually be helpful to have had a break and have stepped away and come back fresh when the others might be pretty exhausted by this point. Mm-hmm. Here's a question also. This one is for you, Deb. I appreciate Professor Marin's reflections on chaplains being open to reassignment. I'm wondering how chaplains who may be at a higher risk of infection have been able to cope. Secondly, how do departments that have had chaplains contract the virus been able to reintegrate them into the team?
So actually, except for the acute spike of chaplains that were affected early in March, and it was just due to sheer bad luck that somebody had, it's a long story. The bottom line is that except for those folks who were exposed early on, we did not have any more problems with chaplains getting sick. It is true that the chaplains who were sick, one of them in particular, the two of them were very sick actually. They felt bad that they couldn't work actually. And the biggest thing, which is because that's what chaplains do, they like to help. I think the biggest thing that we could do was to let them know it's okay. In fact, one of our chaplains who was sick came back, we'll say who it is, amazing chaplain. And this person got sick again. I told this person, you're working too hard. She's working from home, and she got sick again. So I think the biggest thing is for actually supervisors or colleagues to not expect too much, because it's really take care of yourself at this point in time. I think if anything, chaplains have to take care of themselves. I've been very, very aware of that concern, and that's been my strong message. So it was about the infection, and the other was how we take care of them. So the best we could do is what I mentioned. I do want to say regarding systemic racism, we've taken on, there's a lot going on everywhere, we know that, but we've taken this on full throttle actually at Mount Sinai and the Center for Special Health. We're initiating many initiatives actually, because part of this issue is that issue about not only with one another, but with patients. You know, very concerned about that, and we don't mean to do things that we do. So we're taking a new eye, looking at that. And I will say one thing, we have a wonderful chaplains and community engagement chaplain, which is what chaplains can do. Wendy, would you have that? This chaplain, in concert with other departments at Mount Sinai, has been working with our faith-based organizations now for years. And everything's now virtual we're doing. We're training people to be health advisors, the congregants. But we find that the chaplain, we're teaching congregants not only about some of our COVID stuff, but also what to look for in their congregations regarding post-traumatic stress disorder and depression. So to your point, I do think that there's an opportunity in this very challenging environment, which hopefully will be opportune for good changes, that could be an important role that chaplains play.
Thank you, Deb. I know we've also pivoted some of our chaplains who are more vulnerable to doing telechaplaincy, particularly with families, and earlier on, before anyone was allowed in the room, with the COVID patients as well. And that was really, really helpful, both for the chaplains who were on site to be able to focus their attentions elsewhere, but also for the families and the staff, knowing that there was someone else who could reach out. I don't know, Tahara, if you've had experiences as well.
Yeah. Yes, if I'd like to add, we did have a student, a CPE student, who provided telechaplaincy at her congregation. We had a clinical placement agreement where she could go and check on the elderly through phone. So she did that with us. And another thing I want to say about when someone, whether it's a chaplain or anyone within the health system who contracts COVID and then comes back, what I've experienced here, that some of them felt uncomfortable and a little bit of a stigma around having had COVID. And so there was an opportunity for support and care for those who were returning back to work after having contracted COVID. And some of the challenges they faced with some of their, coworkers, being fearful of them, or just some of those dynamics. So that was an opportunity for us to provide some more care, and it gave us something that we learned about, when people re-enter into the healthcare setting, what might they be experiencing after having contracted COVID. So it was an opportunity for us to learn and provide some support.
Thank you. Here's another good question. I'm struggling at the hospital where I work because admin is asking us to help staff with debriefings, etc. after work hours. However, staff have clearly said to us we're too tired to stay and talk after the shift. How can we, firstly, help admin understand the need for support during the shift, and two, continue to offer support during their shift beyond rounding? And then this person has added in parentheses, I do check on staff each day. I am here and have good connections, but it's clear more is needed. Wow, that's a big, big question. So whoever wants to jump in on that one. Wendy, why don't we start with you in terms of advocating with admin? Any thoughts on
I was
that?
going to leave it for Deb because she has done this work. I mean, I can tell you, we have another webinar on Thursday where we're going to be talking about how healthcare executives think about chaplaincy and spiritual care. This was a project with Deb and others, and the data was gathered before the COVID pandemic. But it's interesting because one of the surprises in those data is some executives understand a bit about spiritual care and chaplaincy, some don't. But they talk a lot more about staff care than we had ever expected. And so that seems to be one of the important contributions that executives see chaplains able to make to the system. But I defer to Deb and Tahara as people who are in the trenches where I am not to make suggestions about how to do that or help executives better understand.
Mm-hmm. Yeah, we have done debriefings after our shift has ended to catch maybe some of the third shift employees to make sure that they don't feel forgotten. So we've had debriefings on first shift, 7 to 3, second shift 3 to 12, and then the third shift would be 11 or so to 7 in the morning. And we've adjusted our schedules that way, where we were able to adjust our work schedule a couple hours or something in order to come in at a later time or early to catch that third shift. That way, none of the staff members feel left out. So we have done that. And that was an alternative we gave instead of just saying late. You know, this is what we did is we took more ownership of it, of the debriefings, and presented the leadership with our plan on how we were going to accomplish the goal that they had for us. So I don't know if that would work for this individual. Could they, you know, adjust their work hours so they can provide support at the different times of the shift? That was something that worked out really well for us.
We did the same. Chaplains figured that out already. We actually have chaplains, the way we don't have chaplains available to work 7 days a week. We started a while ago having chaplains come in on the weekend and they get a PTO day during the week so we could cover staff. This issue about taking time, I think it's a great model, Tahara, and I think that's one. I also think that chaplains have to let leadership know that they can't be the only ones to do this. And there's a return on investment on taking care of employees. Anybody in patient experience knows if your employees are burnt out, you have a problem. So, you know, I would use that mantra, plenty. That's why I mentioned about the database. I'm not selling my database. I think you have to show. Another thing is that if they want the chaplain to stay longer, that person's going to get burned out. And also, what about patient care? They have to take care of patients, you know. So I think the chaplain, if they have the right channels, should, you know, to change. I think flexibility is important. I think to dig in one's heels and say, I can't do that is not what I would do. I, you know, make this statement about what about this, and at the same time, let's work with patient experience. Let's talk about what needs to be done.
Deb, what are the best strategies you have found for helping people at the executive level understand that it sounds like for this person, the staff want to go home, they're tired, right? They don't want to debrief outside of their hours. So the chaplains could try to switch their schedules. They'd be able to see people while they're working. But if there's pushback about doing the debrief while they're working, how have you found it most helpful to enable executive colleagues to sort of hear the frontline staff saying, I'm too tired, let me go home, I want to do this, or I need to do this at another time?
This is where data matter. You know, I think that if a chaplain's saying, so I have now debriefed 50 people, in addition to what I have to do with my 6 to 10 patients a day, and you want me to document in EPIC, right? Because you want to make sure that their staff know. So let's do math on this one. You know, I really say this is where you need data. You can just do a week or a month of data, but say, I've now done this. What I've experienced is gratitude, you know, and these staff are hurting. What's HR doing? What's the employee assistance program doing? I wouldn't say like put it on their own. I would say let's work together to figure something out. Wendy knows how I feel about this. You know, it's very important to have some proof of what you just said. I just did 200 people this month, in addition to my when I have to take care of patients. This does not have longevity. Mm-hmm. This is a workaround.
Mm-hmm. It may not be helpful to say this at this point in the pandemic and everyone's exhaustion, but based on the interviews we did with these executives, I have a blog in my head. I haven't written it yet. It's going to be titled Data is Not Symbolic, because we heard a lot of directors of chaplaincy departments telling us about the data they gather, but when we tried to figure out what they do with it, who analyzes it, how it informs their decision-making, doesn't sound like that happens too much. So, you know, this is probably not the time to figure out how to make your data less symbolic and more actionable, but it's that actionability, I think, that you're talking about.
Correct.
Thank you. Here's a question that I think is somewhat related to this. I'm one of 7 chaplains with a hospice. There's no formal spiritual care presence with the administration/leadership. How might we move forward with this?
I wonder who the person reports to. So, I mean, I think the question is how to work up through the line to share with your supervisor and the supervisor's supervisor what your work is. Another blog yet to be written is about managing up. And, you know, managing up is a sort of technique often talked about for how you work in a way that solves your supervisor's problems and how you make their lives easier. And I think that chaplains could benefit from learning a lot about managing up. So what can this person who's writing help their supervisor know, and in what form? Is that a bulleted list? Is that a long summary? Like what are the normal ways in which people communicate to make it as easy as possible to sort of send this information up the chain so that hopefully you can get it as far up as possible? Sometimes there are blockers and then you have to figure out workarounds, but I would start by thinking about how to manage up and share the information about what you're doing in a way that makes clear how you're solving problems that your supervisor cares about.
You can also have people on the team manage you up. You know, there's got to be a nurse, there's got to be a doctor involved in this. And if they can, if the 3 of you can figure out a way to show to the supervisor, you know, tangible reasons why that person is necessary, and how they can exact them, and they have ideas of how to make things happen. That's not necessarily a cost. It's another way.
And I also think because hospice has that natural interdisciplinary meeting all the time, and they have the medical director, the nursing, everyone's right there. So perhaps this individual can take a more leadership role within the IDT meeting in bringing the spiritual support in that environment where they're consistently meeting together and debriefing together. Maybe they can come up with some ideas how they can take a greater role in that.
Okay, thank you. And here's another one. Our program of all-inclusive care for the elderly is putting together support for staff. We work both remotely and together at sites. Can you suggest any particular models for staff care that might be best places to start?
Deb, this one's yours.
Yeah. So some staff are at home and some are.
I would say that we're kind of, I'm using a really bad analogy. People say, it feels like what we're doing is we're building the planes we fly at Mount Sinai. But I will say that other organizations, particularly Office of Wellbeing folks, you know, one way to go is to partner with those different offices. And I'm sure Cedars-Sinai has a good one. We've been in contact with the University of Michigan just a couple of days ago, contact with the University of Texas often. So one way is to team up with Office of Wellbeing and Resilience and also psychiatry to think about what they want to do to destigmatize that maybe it's okay to get help and make it easier for employees to get help. That's always been a challenge, you know that. That's one possibility. You know, I'll keep you posted over the next 3 months. We'll have data, you know, on what works and doesn't with these resilience workshops. They're a peer-led model, so it's very cheap, you know, and it may be that, and resilience can be enhanced. We know that there's a lot of data on that too. So, you know, one can look at that model as well. I'm happy to talk with anybody who's interested in that, you know, what we're doing, but it's another way of going. And there's also work in the military by chaplains about meaning making and resilience building in the military. So I think that there's some good data out there, I believe, on research in that area too.
Thank you, Deb. And here's a question that I think would be good for Wendy or for you, Deb. I'm curious how folks are documenting the impact of chaplains in staff care or with families during COVID, and setting up research or QI models for crafting effective research questions.
So there's a group of chaplains associated with ERIC, the big European Chaplaincy Research Network, and they ran a big survey that we're just being able to look at the data from to look at how chaplains in the US, the UK, Europe, and Australia respond in the midst of COVID-19, just trying to figure out the answer to those questions. The papers are like being written as we speak, so I don't have any answers for you except to say that the data that will help us think about this is just coming out. I think the challenge on all of these questions about staff care is that there's not a lot of information. So, you know, there are a few different papers, and they're on the website actually of the Transforming Chaplaincy Project, of how chaplains have done staff care, but there's not enough that's outcome-based. And I think this is the time to be figuring out how to do those QI projects. I don't know, Deb, if you've pulled other examples in healthcare that you're using as models as you try to design your interventions. I mean, the peer support model is one. I'm just trying to think about where we look when we don't have the models for our settings that are close that might help us figure out what the right thing to do is.
So, you know, we published a couple of papers in nursing journals about how chaplains and volunteers trained by chaplains, it's something called She Time, which we're probably going to rename at this point, but it's a staff care model that's based on Japanese tea ceremony. And we have published how individuals who've experienced She Time are more engaged with their work, with patients, and they feel that administrators taking care of them. I think that that's an easy kind of lift to do. Actually, it's anonymous survey and just giving you some ideas. HR did pay attention to that. You know, I think a lot of the performance improvement, and I think, you know, it's you know, there are a lot of chaplains there now who understand the basics of research. I think, you know, probably this data. One thing I would say, it'd be nice to have just like what we're trying to do with our new center, the stress resilience personality growth thing, is a lot of people are building them, and just as of Friday, decided with another major medical center, maybe on a consortium. And it may be that centers that have the bandwidth to do this, but they need to maybe get together, and it's more powerful if you can do something with multi-sites that have been COVID related, get data quickly. That's another possibility too.
Thank you. And here's one to Deb again. This one might be more to you, or Tahara, perhaps you could speak to this as well. Can someone address the parallels between sorry, let me try that again. Can someone address the parallels between mass casualty care, for example, military chaplains, and hospital staff chaplains experiencing a high volume of deaths?
Wow. I would say with COVID-19, the challenge for staff in the hospital would be just that, seeing the high volume of death, and the added layer to that is that sometimes family members aren't able to be here when the deaths are happening. It's very similar parallel with the military, that oftentimes when they have the mass casualties, they're dying alone. So there has been a parallel with that. So we've been trying to provide support for our staff around, you know, I think I mentioned it earlier about struggling with moral injury and struggling with, you know, coming into the field of healthcare to care for people, to care for families. Everything that they've been training to do has somewhat been taken away from them with COVID. So the grief of that, you know, what has been lost, you know, how our healthcare workers are feeling about the care they're providing. Some people that feel like they're not providing the same level of care that they should be because of COVID. So I think there is a parallel around the grief of how everything has changed, one, and how our healthcare workers are experiencing high volumes of death, and oftentimes or sometimes the individuals are dying without their loved ones present. So I think there is a great parallel there, and that we have to recognize the grief. And the quote that I read earlier from the Dictionary of Pastoral Care and Counseling says, this grief isn't just with people who are sick and ill. What about the families who aren't able to come? What about the loved ones who aren't here, who are trying to get on FaceTime, who are trying to get on iPads to, you know, virtually be present with their loved ones who are here? Parallel that with military families who are getting a call or trying to reach out and get information. So I think there's a huge parallel, and there's a sense of helplessness that I feel personally with it at times. You know, how can we bring families together in a time where we need to stay apart. And it's just really hard. It's a difficult situation. Very difficult.
I agree. I think the concept of telechaplaincy, like telehealth, is here. What we're doing actually is we have batched new residents and Chaplain, who was another hospital in a system, now a new one, and we're actually getting the chaplains geared up to be able to do telechaplaincy again. That's one thing, get their VPNs up and running, make sure they have the right work phones. So we're not kind of nailed the way we were before, but I agree, Tahara, what you said, it's very similar. And the problem is that it's the death and the ongoing fear. You know, New York is a very tense place right now. You know, I mean, you know, don't know, the neighborhoods where people of color live really decimated. I mean, we work with a church in the Bronx, this wonderful pastor. I mean, he got 6 kids, and everybody was sick in this family. There's so many deaths in this congregation. So there's people are upset and scared. And I think in any urban place you live, and elsewhere now, you're kind of planning ahead. And I think meaning making, chaplains are very good at meaning making. And I think having people reach into what gives them meaning and to recognize that they did the best they can by the moral compass. These are things that chaplains are trained to do. I would take that out of their bag of, you know, what they've learned and really, you know, go there.
Well, maybe I can add that when we talk about parallel and we go back to what's happening in our country. So we have, even with COVID-19, we have individuals who have their own fears. Well, I apologize for my phone. Who have their own fears of the disease, and you have people of color, brown and black bodies, that not only fear the disease, but fear, you know, what could happen to them if they go out and protest, or what could happen to them if they have an encounter with, you know, officers. So it's another place of fear and anxiety and stress for minority communities, that not only do we have the COVID-19 pandemic and the uncertainty of that, but it's the uncertainty every day that you walk out to your front door about, will I be safe, you know, within this family. So I apologize for my phone. I'm so sorry.
Tahara, I'm glad you're raising that, and I'm sorry we need to raise that. Michael just put the ebook we did with the lab in the chat box. We took a very encompassing, broad view of grief here to recognize the very different forms of grief that many are encountering on a daily basis because of the color of their skin and where they live and who they interact with, and the long-term effects that that has, as well as the grief of so many of us seeing more death on American soil than any of us have seen in our generation. So the ebook's not the answer. I think acknowledging, again, this double pandemic is just really important. Yes, I think we're probably here out of time. Michael, do you want to wrap us up?
Absolutely. Thank you. And thank you, Pam and Cedars-Sinai, for hosting this conversation. It's timely, it's necessary. You know, I'll echo what Wendy said. We all wish it wasn't necessary, but I'm really grateful that we have leadership in Tahara, in Deborah, in Wendy, and Pam to share their insights. So thank you for that. I just want to mention we have a couple of webinars coming up that will be of interest. On Thursday, we will have the webinar that is reporting on the project that Wendy was talking about on healthcare executives and how they make decisions around spiritual care. So I would encourage you to register for that. I just put the link into the chat so you can do it there. And then also later in September, we will have another webinar with Cedars-Sinai on diversity, equity, and inclusion in healthcare. We're still setting up the registration for that. So that will be on the Chaplaincy Innovation Lab website here just in the next day or so. That's that second link there that has our general webinar schedule. So keep an eye out for that as well. We will join Cedars-Sinai again for that webinar. So once again, thank you to our panel. Thank you all for joining us this afternoon. This has been recorded, so if you came late, you can always go back and watch it again and get up to speed. Thank you all very much. Have a great afternoon.